afternoon, everyone. My topic for today is treating HIV/HCV co-infection, current therapies, and considerations. Next slide, please. I do not have any conflicts of interest. Next slide, please. The views expressed do not necessarily reflect official policies of DHHS, nor does mention of trade names, commercial practices, or organizations imply endorsement by U.S. government. Any trade or brand names mentioned during this presentation are for training and identification purposes only. Next slide, please. The objectives of today's talk is to understand the goal of treatment, evaluate patients before treatment, and treat HIV/HCV co-infections in treatment-naive populations. Next slide, please. All right, so initially, back in during the phase of interferon therapy, you will notice the sustained virologic response in percentage, which I noted in the y-axis here on the slide, and it was very low. But currently we have DAA, so direct-acting antivirals for therapy of hepatitis C, and we have an extensive SVR rate, or sustained virologic response rate, which is over 95%. And this includes individuals with co-infection with HIV. They still have an extensive success rate and very few side effects. So I encourage patients to start DAAs in their HIV/HCV co-infection population. Next slide, please. Why is it that infection with Hep C is very important to eradicate specifically in the HIV population? If you look at the slide, it actually talks about individuals with cirrhosis. And for HIV negative individuals, where you can see the purple line, they kind of plateau. They have steatotic liver disease, cirrhosis, and the incidence doesn't seem to be as high as individuals with HIV co-infections, where there is a divergence that you notice in the graph and an increase in the amount of individuals with cirrhosis, which is exponential. So it's important to identify this subgroup of population and treat them early to prevent this complication. Next slide, please. Cirrhosis, just for context, occurs about 12 to 16 years earlier in individuals with co-infections as compared to those who have HCV monoinfection. And for persons living with HIV who have a co-infection, liver-related morbidity and mortality is a prominent non-AIDS related complication. And of course, we have excellent antiviral therapy for HIV treatment to this date. So it's very likely that their mortality is going to be secondary to cirrhosis, and it could be up to 80 to 90% of liver-related deaths. Individuals with co-infections also have decreased access to transplantation because not a lot of centers here in the United States offer a transplant for individuals who are HIV positive. And of course, that trend is being shifted, thankfully, but we're still not there yet. So it's important to recognize and prevent this complication by therapy for Hep C. Next slide, please. In terms of pre-treatment, the laboratory workup to assess is very similar to individuals who are mono-infected, but just briefly going over the pre-treatment workup, you absolutely want to get an HCV viral load, so you get a baseline, and after your DAA therapy, you can monitor to see if they have a decrease in HCV viral load progressively. And you also, of course, want to start with other hepatitis antibodies, specifically to determine if they are immune, and if they're not immune, they would qualify for vaccination to prevent concomitant insults to the liver if they get additional hepatitis besides Hep C. And you would also like to get an LFT INR, which is necessary to calculate the Child-Turcotte-Pugh score, a CBC, BMP creatinine, and GFR. Next slide, please. This slide basically goes over technology that we have to this date to assess fibrosis. I would encourage everyone to start with the FIB-4 score, which is a completely non-invasive method. You can just plug in certain parameters like transaminase levels into the FIB-4 score and then determine if they are cirrhotic based on that. And it has a very high negative predictive value at a certain score. And of course, if you are having an inconclusive score, there's other testing modalities which you can undertake. No single non-invasive method is recognized to have high accuracy, and you can actually concomitantly use two modalities, especially if those scores are borderline. Liver biopsy is seldom necessitated. However, in individuals where there's discordance between the elastography test results and serum, this will be helpful to impact clinical decisions to see if they're cirrhotic. And individuals who are clinically evident to have cirrhosis do not necessarily always need additional staging with a biopsy. There are some insurance companies which may require formal staging, but of course that depends on where you practice and the insurance of your particular patient, which is important to check um, before you order a biopsy. Next slide, please. Regarding chronic HBV co-infections, there is a very important caveat here in that irrespective of whether your patient is co-infected with HIV, it's important to screen for hepatitis B before starting therapy for hepatitis C, because HCV can actually suppress HBV in vivo. And so when you have a patient who has active hepatitis C and you start a direct acting antiviral in this population, if they have concomitant HBV, the HBV will flare up and it could result in fulminant liver failure. And so it's very important to check your surface antigen in individuals before treatment. And if they are positive for the surface antigen, you would like to stage them with a infective E antigen antibody ALT viral load and offer them treatment if they qualify for treatment for hepatitis B before you initiate therapy for hepatitis C. Next slide, please. When not to use simplified treatment. So I will go over a few of these so that you can determine whether it's important to refer your patient, and then I will talk about the treatment options available. And so there are some high-risk individual groups who will require some nuanced care with regards to hepatitis C treatment, and those are the subgroup of individuals with prior hepatitis C treatment. If they have a reinfection, if they have a relapsing infection, then treatment is not very straightforward in those individuals, and this meets criteria for referral to a specialist. Individuals with decompensated cirrhosis, I encourage you to refer to a hepatologist. It's always important to closely monitor them for varices. Hepatology is able to do endoscopic evaluation if necessitated, put them on a beta blocker if it's necessitated, and then also closely monitor them with frequent ultrasounds to see how far they are in their cirrhosis stage, whether they have hepatocellular carcinoma. So there's a few other nuances there. Therapy also becomes very complicated because you want to use a ribavirin in that setting, which has a very high risk of side effects and intolerability. And so this, in my opinion, mandates referral to a specialist for care. If they have a TDF containing regimen with a low GFR, it becomes tricky to manage these individuals, and I encourage you to refer if you're not comfortable. And of course, there are certain HIV regimen that I listed on here. Those regimens actually have contraindications with hepatitis C treatment. And it's going to become tricky to evaluate and treat these individuals. And I'll talk about those HIV regimens again in the upcoming slides. If they have untreated chronic hepatitis B infection and if they're pregnant. Next slide, please. As far as drug-drug interactions with HIV regimens are concerned, the most commonly used drugs which you see in the market, they will be usually an integrase inhibitor and a nucleoside reverse transcriptase inhibitor, or NRTI. So those are the most important things for you to remember. As far as the integrase inhibitor, which is abbreviated INSTI on the slide, is concerned, bictegravir, dolutegravir, raltegravir are the most commonly used these days, and they can be used safely with all recommended HCV regimens. There is one older drug called elvitegravir, which always needs to be boosted with cobicistat, and that one has interactions. So for the vast majority of patients that you may see with HIV, they will be fine if they have integrase inhibitor-based regimen, because most commonly we use bictegravir, dolutegravir, or raltegravir these days. Now, those are combined with nucleoside reverse transcriptase inhibitors, which is the first point on the slide. Now, it's important to remember that there are sister drugs which are very similar to one another, tenofovir alafenamide and tenofovir disoproxil fumarate. They cannot be used interchangeably if you have a patient with hepatitis C as well, because tenofovir alafenamide, abbreviated TAF or TAF in some settings, doesn't have as many interactions, whereas tenofovir disoproxil fumarate interacts with most hepatitis C regimen. So I underscored it and put it in bold for you to actually look at exactly what formulation of tenofovir your patient has before you initiate hepatitis C treatment. As far as the other drugs which we use, you will see these regimens if you have a patient who has a big resistance profile for HIV and they've had multiple regimen changes, or if you have a patient who was diagnosed in the 80s, for example, and who's had long-standing HIV, and there's more likelihood of resistance development, you will see NNRTIs being used, of which doravirine, rilpivirine can be used safely. Other NRTIs, you need to use a drug checker to see if it's safe, most likely not. Protease inhibitors, all of them should be used with caution. Protease inhibitors always need a booster, which is either ritonavir or cobicistat, and that booster doesn't only boost protease inhibitor levels, it boosts every other drug your patient is taking, and so increases the chances of side effects. Next slide, please. As far as HCV treatment data in co-infected individuals is concerned, I think I can condense this into one simple slide. And the important thing to remember here is that the studies that I listed here, or specifically, they were undertaken for genotype 1. But the studies also extensively studied these drugs for multiple extra weeks of therapy than what is recommended to this date. So I put the studies on here simply to encourage you to look into it if you're interested, to look at the sustained virologic response rate in these slides. But the actual duration of treatment in the studies do not actually apply to the current standard of care regimen in terms of duration of treatment. We have come to this day and age where we use shorter regimens than what we initially used during those clinical trials. And the four important ones that I want you to remember, of course, the generic names are complex, but I would like you to remember that as Zepatier, Mavorite, Harvoni, Epclusa, and all of these can be used safely in individuals who are HIV, HCV co-infected, and they can be used in renal dysfunction, even if they are requiring dialysis. Next slide, please. All right, we will go over each of these regimen and talk about duration of treatment and genotype that you can use it in. Some of you may be able to recognize from the previous ATC Echo sessions that of these four, there are two pan-genotypic regimens, which means regimens which can be used for any genotype, and that's Mavorite and Epclusa. So the other two listed in the slide, Zepatier and Harvoni, cannot be used for any genotype. Zepatier, for example, can be used for genotype 1 and 4, and we treat for 12 weeks. Next slide, please. For Zepatier, there's an important caveat. If you have a genotype 1, you need to check for something called a NS5A resistance-associated polymorphism, and this test is available in multiple different laboratories. You can order this test and look for the HCV resistance. And what it is basically there are some amino acids that I listed on the slide where you have substitution of different amino acids in these positions, which will result in decreased efficacy to Zepatier. So if you have an NS5A polymorphism, you have two options. You can pick another direct-acting antiviral altogether, or if you choose to treat with Zepatier, instead of the 12 weeks recommended regimen that we usually use, you need to treat for 16 weeks. It is contraindicated in moderate to severe liver impairment. You can still use it if you have a CPT stage A. And there are important drug-drug interactions that exist, not only with the HIV medications that we recently talked about, but also anticonvulsants, immunosuppressants, especially cyclosporine is a big one that interacts, and herbal products. Next slide, please. Now, going to the second drug that's listed here, Mavorite is pan-genotypic. It can be used for genotypes 1 through 6, and you treat for 8 weeks. And as you can see, this is a shorter regimen, and the 8-week treatment is really lucrative. This is why most physicians pick Mavorite. Next slide, please. There is a risk of HPV reactivation that appears on the drug label, although this is an important risk to consider in any individual with hepatitis C, the risk of hepatic decompensation. If you have a patient who you are concerned about decompensation or you feel like is in the brink of clinical decompensation, you want to avoid this drug because if you initiate Mavorite, it could push them to decompensated liver disease. And of course, it's contraindicated if your patient is diagnosed with decompensated liver disease. There is drug-drug interactions that exist with anticonvulsants and herbal products. Next slide, please. The third drug that we'll talk about is Harvoni, which can be used for genotype 1, 4, 5, and 6, and it's a 12-week regimen similar to Zepatier. Next slide, please. Harvoni also carries a drug label with a risk of HBV reactivation. There's no renal dose adjustments like we talked about, including ESRD on hemodialysis. It causes symptomatic bradycardia with amiodarone, which brings me to my request for you to do a drug interaction check on any individual who is on anticonvulsants, antiarrhythmics, herbal supplements. And you cannot use it with P-glycoprotein inducers like rifampin or St. John's wort. But there's other P-glycoprotein inducers as well. These are the most common ones I encounter, so I listed them on here. Next slide, please. And the last drug here is a pan-genotypic regimen, can be used for any genotype, and it's also a 12-week regimen. Next slide, please. There is a risk of HBV reactivation, no renal dose adjustments, including ESRD on hemodialysis, symptomatic bradycardia with amiodarone, and cannot be used with P-glycoprotein inducers. You'll notice this is very similar to the previous slide. It's because the drug label looks exactly the same. Next slide, please. As far as monitoring is concerned, generally for individuals who have hepatitis C, it is important to do the baseline labs, and after therapy, important to check a viral load and perhaps SVR12, which is 12 weeks subsequent to therapy, important to check a viral load. However, for individuals who are co-infected, I encourage you to check a 4-week HCV viral load as well to make sure that they are trending down, at least if they're not undetectable. The 4-week HCV viral load is elevated and significantly elevated, so tenfold from the 4-week level. You have to, if the 6-week level to stop treatment, and there is an expert recommendation that even if it's not tenfold, but if it's headed in the wrong direction, if it's increasing, to stop treatment. I usually recommend just continuation of treatment if it's not a significant increase, and referral to a specialist at that point in time. Next slide, please. Monitoring after treatment is very similar. You want to do a 12-week sustained virologic response, and there's a 99% chance of durable cure. And we also encourage you to do a 24-week response, which is optional. You order, especially if the risk is higher, such as viremia at the 4-week viral load check. If there are adherence concerns that you identified, patient has received a liver transplant, or if your patient is cirrhotic. Next slide, please. Additional monitoring is very important for individuals with diagnosed cirrhosis. Especially because you want to make sure they do not progress to other complications such as hepatocellular carcinoma, and this mandates screening with 6 monthly liver ultrasounds. And when you see your patients, it's also important to counsel them to prevent reinfection. Just because you're treated doesn't mean they are not at risk for getting reinfected. And screening for reinfection is important in certain high-risk individuals, specifically individuals with ongoing illicit drug use history. I always screen them. I recommend annual screening at least for them. And beyond 24 weeks of HCV viral load negative, you only need to check a viral load if there's ongoing high-risk behavior. Next slide, please. The key points to remember are non-hepatologists can and should provide HCV care. The AASLD IDSA HCV guidelines is the definitive source for treatment recommendations. Actually, everything on the slide that I took for today's talk is from those guidelines. Other websites provide helpful clinical tools and opportunities to practice and reinforce knowledge. And the main challenge, of course, is managing drug interactions. Next slide, please. I put some online resources on here. The first one is the Hepatitis C online curriculum, and that curriculum actually is a condensed version of the AASLD IDSA guidelines, which I encourage you to use. And there's a few calculators that you can use for CTP scoring and Liverpool interactions. I will take questions. I think there's another slide of resources as well, if I'm not mistaken. Yeah, and I can take questions now.